Hello, everyone. Thank you for the opportunity to present. I'll be talking about malignant peripheral nerve sheath tumors. Here are my disclosures, and I do want to thank my incredible partners from spine and from the peripheral nerve divisions where I work. I'll start off with a brief case. Some of you may have encountered something like this. This was a 25-year-old NF1 who had a mass coming out of the L1 nerve root, has back pain, flank pain, biopsy proven to be MPNST. We get a PET scan. It shows that it's PET avid. Go in, it's straightforward, retroperitoneal approach, take the mass out, cut the proximal L1 nerve root. We have clean, negative margins, and we high five. And then we get repeat imaging. And to our dismay, just a few months later, this high-grade MPNST comes back hot on PET, low ADC values, prompting us to then need to go back in, facetectomy, more proximal nerve root ligation, and stabilization. This is the problem with MPNSTs. They are so aggressive and they recur so frequently despite our best efforts. MPNSTs are about 5 to 10% of sarcomas. They're rare in the general population, more common in NF1, and some can arise from prior radiation. Survival is poor. And the only thing that is the standard of care is resection and wide margin resection. Adjuvant versus neoadjuvant, radiation versus chemotherapy is still debated, and there is mixed literature on this. Let me talk a little bit about what's out there. This study out of the University of Miami, 250 pediatric patients studied from the National Cancer Database, showed median survival of about 5 years. Subtotal resection, biopsies confer a worse prognosis, no significant advantage with adjuvant therapy. Mayo Clinic, Sloan Kettering, MD Anderson, all within the past 10 years published their series, all showing about a 50% 5-year survival, worse in NF1 patients, worse in radiation-induced tumors, better in sporadic. Truncal tumors, those of the plexus, those of the spine, are more challenging to manage and therefore have a worse survival. And the AO Knowledge Forum did look at that specifically. They looked at MPNSTs of the spine with only 1.3 years survival showed a 48% mortality. And of those with local recurrences, very high chance of mortality. On block, not on block, didn't confer any advantage. Adjuvant therapy didn't help. And why is that? Because even when you get that negative margin histologically, there can be spread along the nerve. Can it be further down, even beyond what the pathologist can see? MPNSTs are heterogeneous. There's atypical premalignants versus malignant tumors. And when we're trying to get a 2-centimeter margin beyond the tumor, sometimes in the spine that can't be achieved because of the challenging margins. And so going back to that recurrent theme of recurrence, you look at that MD Anderson series that showed that even with R0 and R1 resection, more than a third of patients recurred at a year. Those with bigger tumors, those with positive margins, have a higher chance of recurrence. And in their series, they did show an improvement with adjuvant radiation. Now, if you come to our sarcoma board at Hopkins and you propose radiation for any of these tumors, that knee-jerk response is absolutely not. And the reason is that we're so worried about it is for malignant transformation. You radiate a plexiform neurofibroma, you radiate someone with a high burden of neurofibromas, there is a high concern for malignant transformation. But there is a body of literature on this, and we do use it sometimes. In this group, here they showed a 46.5 median survival. Radiation did not predict survival. In contrast, you look here at this group from Sheath, Berlin, they showed a significant advantage with EBRT after surgery in terms of overall survival. What about stereotactic radiation? Sloan Kettering, they published an improvement with high-dose single-fraction radiation. Another group did not show the same. They actually showed the opposite. So where does it stand? What do we do? Number one, every single patient with MPNST gets discussed in multiple multi-D discussions. For imaging, we get PET and or MRI with perfusion and diffusion sequences. At our institution, an ADC value of less than 1 suggests atypia or malignancy and should warrant intervention. And if patients get routine surveillance, and we discuss it at NF Tumor Board. This patient, 43 female, NF1, is getting that surveillance every single year. She starts having sacral pain. We get imaging. It shows that her deformity is progressing. The tumor is further eroding her hemisacrum, and it's PET avid. Biopsy came back as atypical, a premalignant tumor. We want it out. NF tumor board wants it out. For anubip, for premalignancy, we do intralesional resection, and here we stabilized. What do we think about for biopsy? If the imaging characteristics or the symptoms are concerning, do a needle biopsy. But sometimes, because of the heterogeneity of the tumor, even when it is negative, sometimes we'll proceed with surgery anyway and get an intraoperative frozen pathology and assessment to guide the extent of resection. And if it's benign, we favor upfront resection. If it's premalignant, low threshold for resection because of the high conversion rate. And if biopsy is not possible, we'll do intraoperative frozen assessment to guide our surgery. How do we think about chemo and radiation? Again, every case discussed. We always try to push neoadjuvant prior to surgery, ifosfamide doxorubicin. And the reason is, it's mixed in terms of how well it works. If there is tumor still there, you can assess the responsive rate of the tumor to the treatment. If the tumor is out, you don't know if it's working or not. So we try to do it if possible. And again, if there's significant plexiform or neurofibroma burden, we avoid radiation. For subtotal resections or breaches, that's when we treat with adjuvant chemo and radiation. For recurrent tumors, we try to always reoperate. If it's inoperable in the spine, we'll go proton or SBRT. In the extremity, sometimes amputation. This was a particularly challenging case, 37 female, no syndrome as far as we knew, but she had a CP angle schwannoma resected years prior. Then she had an L4-5 tumor, looks like a schwannoma, looks favorable. We go in, you resect it. Unfortunately, to our dismay, a few years later, it comes back despite the fact that we had taken the whole thing out and treated it with proton once we got the diagnosis. Here you see this little nodule of resection, but the whole tissue is all proton radiated. What do? We go in, facetectomy, and take it out. But then again it recurs. This time it's in the facet, it's in the foramen, it's going into the fusion construct, it's in the telos, and this required a much bigger operation. This is what we call our telopectomy, and we had to do a very wide, aggressive resection to try to save this girl from having further recurrences. Ultimately, on-block resection is what we want. R0 margins are preferred. If the MPNSC is within a plexiform is the margin. You take out the malignancy with plexiform around it. Usually there's a different consistency surgically, but we also use anatomic and imaging landmarks. And for spine lesions, again, we try to ligate the nerve at the dural margin if it's intraforaminal. And distally, we'll go 2 centimeters beyond the mass. And intraoperative margins are critical. Transect sharply, do not cauterize, assess if there's any question, atypia or anything like that, go another 2 centimeters because of how aggressive these tumors are. Thank you very much for your time.